Dr. Godoy. So let's talk about external fixation. So then this is going to be just, a run through of what the frame looks like, what it's good for, and then at the end, what kind of different frames that you've put up, or that you can put up, okay? So frame building 101. What's the purpose of using of the external fixation device? Maintain length, hold up the fracture, maybe get to those areas where you can't really put any internal fixation, right? Or if there's an open fracture or an open wound, you can't really use internal fixation on that until the area is clean, until you get proper graft covering or a skin substitute covering the wound. And so an external fixator is great for that, right? But other reasons, to anchor multiple osseous fragments together through the use of wires and rods and provide longitudinal support, which is basically what you said. Decrease the need for extensive soft tissue dissection, and provide immobilization and the ability to perform compression and distraction at multiple sites, and the ability to gain easy access to soft tissue defects, and provides for post-op adjustment. And also the main thing that I use it for, as well as these other things, earlier return to full weight bearing and range of motion. After I put these frames on people that Charcot, the day right afterwards, I make them weight bear with physical therapy. They're walking down the halls, they're walking up and down the stairs with physical therapy because, like this area, I work in Harlem, and so they are constantly walking up through their apartment buildings. I also work with a lot of the Medicaid population, and so often, they don't have money to be able to stay at a facility for long periods of time, right? So they are basically on their own. This is one of the main things that I love from this. It's able to sustain whatever it is that I just reduced within this area, and it's able to support them enough to let them walk. Now, it's walking to certain areas in their kitchen or in the bathroom. Yes, when they go downstairs, it's better for them to, get a cab to come to the hospital, but at least they can put some mild weight on it to pivot, okay? All right, so can provide immobilization with the ability to perform compression distraction. This is one picture of one of my patients. You see here on the right had a ankle varus deformity with also a limb discrepancy of 1 centimeter. So we were able to reduce his deformity at the level of the ankle, but then also lengthen him the appropriate amount in order to give him equal limb length, right? So then later on, he doesn't put a lot of pressure, let's say on the hip or on the knee of the contralateral side or ipsilateral side, damaging those joints more, all right? The patient that has an fixation, as long as you're putting those wires away from the wound as much as possible, you're able to do your wound care, put grafts on, bring the patient back to the OR, and perform this life-saving wound care that they so desperately need. Provides for post-op adjustments. Okay, so I do a lot of this. I go in for the first case. Let's say the patient has an infected ankle or a septic ankle, right? I go in there, I put an antibiotic spacer, leave it in there for about 6 weeks, come back, take it out, and now I'm ready to put in my graft or to be able to do a tibial osteotomy using the Gigley saw. This is how I usually do, and everything is done percutaneously, is that right? So those are my residents holding it out. We've performed our percutaneous skin incisions. We put the Gigley saw through, and then as long as the frame is stable, you're able to perform your Gigley saw osteotomy and cut your tibia. And you see there, and I don't know if you can see it, but right here there's a Steinman pin that you have to push back below the area of the tibial osteotomy, or then you're going to just break the Gigley saw and you're going to have to do it all over again, right? So that's one of the things that we kind of learn the hard way sometimes. About early return to full weight bearing and range of motion. These patients are all patients that live in NYC, and they're able to come and go forth with their external fixation devices, and they live with them for about 2 to 3 months. Modes of fixation, again, Compression requires sufficient bone stock to intimate bony contact. Neutralization maintains length and alignment, resists external deforming forces, and then distraction, reduction through ligamentastasis, callus distraction, and arthrodiastasis, right? So whether you are trying to reduce a ankle varus deformity slowly, or you are trying to distract and make callus formation in order to get to fix that ligament discrepancy, it can help you with all of that. How to safely apply these devices, right? You need to know where to place the pins and the wires, avoid damage to vital structures. Frame should allow access to the area of injury and should meet the mechanical demands of the patient and the injury, right? You're not going to use a 4.0 apex pin on a 300-pound patient. You have to use the appropriate wires on the appropriate patient, okay? You can reduce deformity acutely, or you can reduce deformity through gradual reduction. And those are more for large deformities, useful for if you have structures or risks that you do not want to reduce right away, because let's say you have a patient that has a clubfoot, right? And let's say you do a talectomy and you're able to reduce that deformity. One of the main things that I've found is that a lot of these patients, if you reduce that acutely, even if you're taking out the talus, they're still going to have a lot of pain, neuropathic pain, right? Because you're stretching out the neurovascular structures. So you've just got to be careful with that. A lot of those patients too that I reduce acutely, you have to watch out again for the vascular structures. You can form a bigger wound, okay? And I do see a lot of that. So I try to do it gradual if I can. Acutely is obviously a little bit more simpler, right? Because you're able to reduce deformity and then just apply the frame afterwards. He had a sequestrum within the subtalar joint for at least 20 years that wasn't able to be fixed, or nobody fixed, right? So through that incision, we were able to take out all the infected bone with an antibiotic spacer. But you know what? He did end up with a couple of wounds in there that then we had to treat slowly. And here you go for gradual reduction. This is a 13-year-old male who was born with bilateral metaductus that we were able to then make percutaneous. It cuts through the bone and then slowly bring him out to a more normal position and give him less pain. Home blocks from school, he used to just be in so much pain because the shoe was just very painful for him, rubbing but you do need to speak the language, right? So now you know what you can use it for, so what are the parts? And that's what we're going to go through soon, right after this, okay? We'll go through components. Most of the things that I use are carbon fiber, but you also have aluminum available. That's the carbon fiber. And you have all a slew of different sizes. You can have an open U-plate, or you can have 5/8 rings, or several different other types, and you can connect them as you see fit. These are the foot arches that I always end my frames with to give it more stability, all right? And you'll see, we'll build the frame and put that on there. This is something that I love, and I love the way that Stryker actually has them. It's just very versatile, very easy to place on. I see a lot of other companies, and I use other companies too, I don't just use Stryker, but you know, sometimes it's just three or more components that then can get loose, right? So this is just very easily one component in the front, one component in the back, with a little nut that you attach them to. All right, and if you can't get it at the right place, you can also offload it to be able to do that. Now this, you see in this picture, you know, we're usually supposed to have this right here, right? But this wire is in the way. So we were able, with the connections that they have, to be able to extend it just medially or just laterally, wherever you want. Okay, so we also have, and those of you, and you probably don't know this, but when I was a little baby podiatrist, what we had was threaded rods, and they were the bane of my existence, right? Because you had to count the threads and make sure that they're you know, accurate on all levels, right? So this is probably a little bit much, but I knew that when I was a resident, you needed to have 10 centimeters from the tibial segment and then 10 centimeters from the tibia to the foot segment, and I needed to count, and I needed to be accurate because I don't want that frame uneven, okay? So that was our responsibility. We built the frame the night beforehand, we put it in the autoclave, and we had it ready for the case. And as a first year resident, you better know all your parts, and you better know what they want, right? And have it all on your little table there to be able to pass it through them, right? So you went through the stages. As a first year, you were a passer, and then in the second year, you held the foot, and then as a third year, you actually placed the pins on the leg, okay? So you didn't just skip. Okay. So these are static struts. I also hold these to hold my tibial segment. So instead of threaded rods here, this just makes it so much easier to have your tibial component, and we'll build it. We're going to build it that way. You have different. You can either have what do you call it? Smooth wires or olive wires, and the olives, just know that they're on the segment that is with the stripes, right? So it makes it a little bit easier for you to know where the olives are, and when you're taking off the frame, that you don't pull through the olive through the bone, or at least start trying to do it for half an hour before you take off the frame. Wire bolts and wire bolt adapters are also something that we use in order to attach the wires to the frame, and you'll see that. Here we have your wire bolts and your wire bolt adapter. This is something that I really love on the set. It's, I call it your, gosh, now I can't remember the name, but it's a little bit longer so that you're able to reach your wrench to it. So the usual nut is about this long, but this is something where you can actually reach over it and are able to use the wrench if you have two nuts really close together.
Just a long M8.
Long M8. I used to call it something different. That's why I'll think about it. Okay. Pins. These are things that I use on my frame. A lot of people don't use them because they feel like the rate of having a tibial fracture increases. I still use at least one per tibial segment. Here I used a lot more. I probably stopped doing that. So I'll use a apex pin on the proximal tibia, and then on the most distal ring, and then I'll put two skinny wires crossing in that area to hold the leg onto the frame. And really that's the only place. I used to put another apex wire through the back of the heel to kind of bring the heel down, use it as a chance pin to kind of direct where I want my heel to go. I ran away from doing that. I felt like there were a lot of complications, wounds that would then form after I did that. So I usually just stay with the skinny wires. I don't usually use what do you call it? The other pins with the olive wires, but you know, that can be used as well to try to move the deformity. If you have a calcaneal fracture that is in varus and short, you can usually use an olive wire to push it out of that position. This is what I use to put my apex pin through the leg, and then you can see how it's used in different areas, okay? These are just different kind of struts. You have telescopic struts, and then you have the hexagonal struts, which are the ones that I mostly use. If you're gonna do deformity correction, usually the hexagonal struts are the ones that are used for that, because they help you run the program through the system, and you're able to reduce it slowly just by giving the patient a simple script in order for them to follow. All right. In here are your gradual correction struts. This is the ones that we were talking about, and you'll see them more in there. Hinge telescopic struts are just different struts you put across the frame. And here's where I mostly use your hexagon struts, and you're able to, you have them in 4 different sizes, extra small, or extra short, short, medium, and large. And I think they're that for a few years, so I'm not holding my breath. Okay, so this is the way that you're running the program. You know, each strut will have a number, and those and they also have a place on the frame. And so you will see where you put the struts on the frame, and then put that into the computer system and slowly, gradually correct your deformity that way. Okay, next about struts optional placement. So they have different placements that you're able to use if, let's say, you have a skinny wire in the way, right? If you have a skinny wire in the way right here, well, there's no worries. You can still put it all the way down here, or if you have a skinny wire here that's going in the way, you can still either go more distally or go more proximally. So there's different ways to be able to fix a deformity, and you're not just cut into one area. I think in the earlier Taylor spatial frames, you only had one position where you could put it on, but now that's changed as well. And so here's usually things that I have in my fanny pack in the clinic, a couple of wrenches, and then struts. And I don't have a fanny pack filled with this stuff. I have a toolbox that I bring to every clinic with me. That's really heavy, but you know what, the amount of frames that I put on, I need extra parts because sometimes they do come a little bit loose, right? This is one present that a resident got me when they graduated, just a little mini wrench in case I run out. The most important, I like to have the heel slightly off the table, place a bump behind the knee to flex the knee. Knee has to be rectus, so if the patient is externally rotated, make sure that you put a bump underneath the hip in order to make them rectus. I always prep up to just above the knee, below the thigh tourniquet, and then I usually draw a line down the tibial tuberosity and down the second metatarsal, and that's how I'll fix my deformity, because usually it starts being off, and then after we're done fixing it, it's usually one straight line, which is what you want. Placements. Apply the wires from the skin directly to the bone. Try to avoid neurovascular segments, obviously. Cool the wire with saline or moistened gauze. I usually do that. So as I'm placing the wire, I have the scrub tech give me a moistened gauze. And then not only does that cool the wire as it's going in, but it also helps me support my hand next to the frame, so I'm able to position it better. Try to drive the wire so that it's directly on the ring. However, if this is impossible, then you can use washers and posts. It's really much better if you try to place it directly on the ring, at least in the tibia. In the foot, I think there's a little bit more leeway to not be 100% exact, but on the tibia, you really want it to be exact, okay? Is off, okay. So these are the safe zones in the tibia, and I'm usually working on area D and E, sometimes C, if the frame goes up that high for the tibial, for the most proximal ring. So if you are going all the way up there, there are neurovascular structures to avoid, but usually within the area of C, D, and E. I do have a lot of shorter patients, so if that's the case, then I'm running into section B as well. Okay, so tibial ring, there's ways to tension these skinny wires to the frame. In the proximal tibia, I tension it to 130, and you're going to see the tensioner and how it works. Tibial block typically consists of two rings between 15 to 20 centimeters apart. You throw the first wire transversely on the superior aspect of the most proximal ring, lateral to medial, make sure it's in the midline of the tibia, and then posterior medial border of the tibia, aim and exit anterolaterally, just lateral to the tibial cresting. These are different ways that you can apply the skinny wire to the leg. So this is the transverse first wire that I try. If you catch the fibula and the tibia, that's okay. Sometimes I go a little bit anterior, and you just have to be careful which section you're asked for the neurovascular structures, right? There's really a lot of space that you have in that tibia so that you're not able to hit the neurovascular structures posteriorly, okay? Ring distal tension, once again, if you're in the tibia, you're tensioning to 130. Distal ring is 5 to centimeters above the ankle joint. First wire, again, transversely, lateral to medial, inferior aspect of the ring. Then you have an oblique wire, superior ring, posterior medial border of the tibia, and aim anterolaterally to the lateral face. As you're getting down closer, the neurovascular structures are getting a little bit closer to where you are. But as long as you maintain your wires in the safe zone, you're going to be okay. And again, the tibia gets a lot wider too, so you're able to put them in more spaces, okay? And then in the foot, your first wire at the posterior 1/3 of the calcaneus, in order to protect the patient from neurovascular injury. Shoot 1.8 smooth wire transversely from medial to lateral, and then fixate to the inferior foot plate. And then your second wire, it can be an oblique wire from the medial insertion of the Achilles to the CC joint. This is kind of hard to do. I mean, you can try it right now. Sometimes I'll just make it slightly more oblique than the first wire, and that's appropriate too. But in this direction, you get more of the calcaneus, and it's more stable. You have to angle between both wires about 45 to 50 degrees, and again, you fix superior, the superior to the foot plate. Then you have the transmet, first wire going in laterally, catching as many metatarsals as possible, and it might be easy to do it in the sawbones. Is not as easy when you're not looking at the bones, right? But you're still able to kind of catch at least the first, second, maybe, and as long as you're able to catch the fifth, I think that's kind of what I get away with. You can also do 2 wires, one more medially, catching the more medial aspect, and then one more laterally. Just make sure that you're not coming out above where the neurovascular structures are by the first intermetatarsal space, okay? So, like to do, sometimes I'll do a midfoot wire and rushing it posteriorly for compression of the midfoot. I do a lot of what's called flipper foot. So I'll fixate my rear foot and I'll make sure that that's intact, but then I want them to have that motion anteriorly. So that motion within the midfoot is called a flipper foot. Okay, placements on there. And these are the ways that it looks like in real life. This is my tensioning Russian wire going along the midfoot. It tensions my midfoot to the rear foot. And then I also place a couple of other wires that I just want in there. I usually put these either before or right after I put on the frame to just hold it within that space, okay? And then, okay, so the last thing is different types of frame. So you really have to ask yourself, is correction necessary? You can just do a standard Lizaroff frame, okay? If it is necessary, are you doing acute corrections? Are you correcting everything before you put on the frame? And if the answer is yes, then you don't need a fancy frame. You can still use a standard Lizaroff frame. Or no, is it a complex deformity? If it's not a complex deformity, let's say an equinus deformity, 20-degree equinus deformity, then you can still use a standard Lizaroff frame. But if it is, then probably a hexapod frame is what you need. I'll still put hexapod struts on my standard Lizaroff frame because I feel like it's a lot easier to manipulate if there's some give. And then you have your miter frame. If you have both a rear foot and a forefoot deformity, you're able to put this contraption on. A little bit more time consuming, but you're able to reduce it the way that you want to. So here you have an equinus deformity, and then you also have a midfoot deformity, and then you're using the hexagonal struts on both sides. I will tell you with this, you're probably going to need an extra long space to be able to attach the struts to, because most of the time you're going to be using extra short, and if you need to compress anything, there's only so much space that you can be given for that. if you really wanna go crazy, this thing is called the Tennessee Torpedo. I've never placed one of these in my life, but I thought it was kinda cool, and I can't imagine that it would be very, comfortable for the patient, to use. And then if you want extremely ridiculous, you have one of these frames, an equino cable varus foot deformity, with equinus correction through the ankle joint, forefoot adduction, and supination correction with the midfoot osteotomy. So there, you can put a frame on for anything if you really didn't want to reduce anything acutely. So I usually just put these both together, and I make sure that this is on top of the other, right? So then I'll go north, south, west, and east and west, and then I'll put these appropriately on there. So I'll do that, and I'll and then whatever you do on one side, you have to do on the other side, okay?
Okay.
So let's turn it around. Before we tighten everything, okay? So we have two more. So you see the first thing? So this is off, right? So let's move that.
Oh, yeah.
So whenever you tighten one part, you hold counter on the other one. Well, not so important with this one, but with the other things, it is. So you should really just get used to it, right? So we'll put this on the top and this on the bottom part here. And so then you hold that, and then you, and then you can hold the frame while he's doing that. And then just do all sides. These are open, and then how you lock them are like this. So then after you put them on, you have to make sure that they're all locked, right? So that's locked. You can start, so that's how you can press. You can start at a larger level, and then slowly, with these telescoping struts, you have to push it together. Whereas with the hexagonal struts, you can open them up, or you can turn the areas right here.
Dial, right?
Yeah, you can turn it, and you can shorten it that way. But with these, you actually just open them, and then you push with full force, and you do that slowly. Okay, so usually with this, make sure that always this is in the front. Right?
They call that your master tab. It's just
Yep. So then you're placing it this way, all right? So then it's going to be offset a little bit. Okay, and then just make sure that this is the appropriate direction, so the locking area is going down, so it looks like an actual lock.
So this is your dynamization wheel too. So you always want that on the bottom. So if you want to dynamize other frames in the past, you have to lose integrity of the frame. So you'd actually literally cut wires. So you put the structure in, and then to get micro motion, you would have to, right? You'd have to just click. So you really just have to weaken your frame.
Yeah.
So, but now you don't have to do that. You could just get micro motion within the strut.
So then I'll usually place them, let's say, I'll count from this right here. So 1, 2, 3, 4, 5, and then 1, 2, 3, 4, 5. So you can put them on either side. Let's actually do 6. So then we'll tie them here.
You want to make sure everything's uniform too, because that could be a nightmare.
Yeah.
If you have to do this on the back table, it's very frustrating with scrub techs, as you can imagine. And everybody pulls off and has to do this.
So this is just the standard nut.
Yeah, so what he's saying is we have to make sure that this doesn't move, right? So how you do that is...
So yeah, you have
Sounds good. Give it a good name.
and then we could use a counter wrench. So they could grow 15 degrees either way. So you just kind of want to get it all squared, especially if you're doing like
See that open wrench?
the majority of people that I've seen that are not doing a lot of frames. They'll still utilize frames, but they'll just fix the Liz frame, like with all MIS techniques and screws, percutaneous screws, and then we put the frame on as more of an offloading device. Yeah. It's also a nice backup too, because you can compress and you can make other
So then
corrections.
you count 1, 2, 3, 4, 5, 6. And I'll go back there. 1, 2, 3, 4, 5, 6. And I'll go together.
So get some more of these black ones.
Yep.
Feeling more heavier and
So always
Not rigid.
want to make sure that you're tight.
Is it? Is that what it is?
And you want to do counter pressure. So,
we also have the ratchet too, right?
yeah.
Why would you use this ratchet over?
Mechanical advantage.
Yeah, sometimes it doesn't work. I'm so used to, yeah,
Yeah.
I'm so used to doing this.
Gotcha.
And then we're able to do the same thing on the other side. So I would still count, like 1, 2, 3, 4, 5, and then do the same thing on that side.
Okay.
You have a washer too? Yeah, perfect. Okay. Yep. So now you're doing it on the 5th one, I did it on the 6th. So move it over one.
Do you try to tilt yours in too to kind of like angulate them in or no?
You know what, I try to do it as straight as possible actually. And then let's do the M6.
Yeah.
Hold on right here. Here you go.
Does that, that's not.
Oh, yeah, that's normal.
This one's good. There you go.
Suturing practice.
And underneath that. Perfect. Okay, and then once again, we have to put it tight, but let's not put it tight until we do this one, okay? So then we'll put this on here, and then
Yeah.
we'll, let's see.
It works really good.
So sometimes you see, you might have to have put it on there first.
So you're gonna put two here that go this way, and then
Right,
two
you
there
can
that go this way.
actually do that. Okay, that's perfect. And then we can do this.
You can go one.
I would try to count as much as possible.
I mean, just, I don't know, I go maybe there, we will see. So you kind of push off top, sit down.
So the good thing about this is that as long as it's
Yeah, usually this is pretty.
unlocked,
And you go and do it.
you know, these can go a little bit up.
Yeah. We were
Or you
working
can
on it
adjust it.
the day before,
Oh, yeah.
and we're like, yeah, and then.
So if you're doing threaded rods right now,
Anything, but
just to show you,
you just know, I gotta put the pins in here.
you would be threading.
I know, it looks weird.
So what you'd have to do is you'd have to thread one
Just
in,
count the whole-
you'd have to thread one
Yeah.
down, and then you have to thread another one the opposite way. We could just throw one on if you wanted to see.
Exactly.
Yeah,
You
like
know?
barbarians.
Yeah.
It just takes more time.
Yeah.
And then you have to, right, and then you slide this in, and then you put them underneath and they compress. So it's the same thing, it's just, yeah, you have no flexibility, right? You can see how rigid it gets, and
This is very mobile.
Yeah,
Yeah.
yeah, for sure. And then let's put
And you
it
can
on
dynamize
yeah,
this,
let's put it
right?
on top.
those you can, yep. In the clinic, you would just loosen these. Up to 5 millimeters. It's actually a great test to see like you have a fusion or if the patient, if it's actually solidified, yeah. Yeah, so if you loosen them all the way up and you take a step and they have pain, obviously the frame needs to stand longer. If they don't, it might be good up. You could use the clinical.
Alright, let's put the nuts on the bottom. The other way, the other way. And that, you need the M8. Yep, the bigger one. Yeah, perfect.
I don't think yet until
Like 2 or 3
when we
like
can.
But like, just, I think it was like, I think it, for, when you do like the case reports, it's like really cool to see how someone is fixated it.
Yeah.
Do
And I
it.
think that was like the tough thing, cause
Oh,
people talk
no,
about
no,
it,
no.
but they didn't.
So maybe, give him one of the open ones
Yeah.
and then
Just
I'll
called
get one of those closed ones.
Yep, you, and like you do yourself a favor and like see how.
Doing whichever one you
X-fix
want.
removal for Dr. Siraki tomorrow, it's a 1 o'clock case.
Okay, did you do the other one?
No.
Okay, let's do it. Okay. So,
In the notes, tell them what the T handle is.
the program, they're slowly taking it out of requirement. So you see they're, all the way in the back it's short, and then at the end, they end up pretty long in the back, short in the front, right? But, you can either, usually I put it on with it locked, and then I can unlock it and put how I usually do it is I'll put the ring, the tibial ring, I won't put these on until the end, then I'll put the foot plate, and then I'll fill them in,
Right.
because it's much easier. If you're doing this, then it will hold you
Yeah.
from doing exactly what you want. So, and then you kind of, you know, you can always go from long to a little bit shorter, but you can't go from short to short. If you're already at the extra short and these are on there, then if you need to reduce it to shorten it more, you can't do that, right? So sometimes I'll take that into consideration, and I might put this a little bit higher in the tibia in my C or C position. Okay, so this has to be orthogonal. And you have to have at least one finger breadth from the anterior portion, but 2 finger breadths from the posterior portion. And you have to kind of
So like when you're putting it on.
like that, yeah.
Most of the time
But then
we
also the
pre-build it
heel
with
has to go
resonance or
like
we-
in the middle
Yeah, we'll pre-build it to
of
the
the
patient,
foot
'cause you don't wanna be
okay?
doing
So now, if you wanna cheat it a little bit and do it like this, you can do that because you can lengthen
So we
this,
had it ready to
right?
go.
And that's okay, because if you lengthen it, then at the end, you're able to get this out further down. But you can't
Yeah, it was not bad.
shorten it
No,
anymore,
it
because
was-
you're at your maximum
because we
capacity.
pre-built
And if you
it
do
and we
that,
had a
if you put it
really
in
good
this way,
frame.
and
Like,
it's too short, then you're gonna have to
Once
change
you
the
start
struts.
putting the frame on.
So you're gonna have to put yellow
You have
struts
to go up a
rather than,
size.
yeah, rather than, so to make it easier for yourself, I would start here,
Ready to go, and there was just one backup.
and then make sure that this is orthogonal, so that the leg is completely in the middle, with maybe 2 finger spaces away from, this anterior portion. The calf is usually bigger, but the anterior skin is not, so pretending that there's anterior skin, 2 finger breadths here is perfect. When you are, in actuality, you wanna be 2 finger breadths away from the posterior calf, right here, but since there's no calf, let's do that here like that. I'll let you hold this. Don't hit her.
We just met.
You just met.
Hello. Okay, so knowing my landmarks, I'd probably go like around.
So the first one we said you can go just straight across, right? Whether you go just anteriorly to the fibula or hit the fibula and go straight that way, that's okay. So put it a little bit further down, yeah.
Is
Down
Sirocco
is
gonna see
better
that
than-
patient or, you know, the one,
Yeah, I don't know,
what's that?
you just have to put an MRI in.
So here we don't have
I mean,
a wet ray tech, so what I do is,
So you see the flat edges there?
You okay?
Think about it.
Me?
Yes.
I'm fine.
You sure?
Yeah, let me sit so I'm more stable.
whose pad is
I
this?
feel like I'm like a
destabilize. So whatever you choose to do first, the next skinny wire is gonna go through the bottom bar.
Okay.
And just go straight. The most important thing is using your body as like an extension.
So try to start it right on the rim. Yeah. Okay, good. So now let's attach it and push it a little bit more.
So I'm gonna text him.
I grabbed some more.
You got
Because otherwise, I think he's gonna go through
Okay, that's good. Okay, so you switch these.
This protects your
for the
hand.
extra short, right? So then you can
Yeah.
just
Yeah, you
full
do it.
frame.
Yep.
So
Put it
right
in,
cheek
and then you're
over
gonna
and
lock
put it
down.
right there. So this way
You can either use the ratchet or the
and then
wrench.
maybe into the
You're gonna lock down one side, and we're
So I
gonna
could put that-
tension the
you can put
other.
where I am, so you don't get hit. You can put where I am, so you don't get hit.
Yeah.
That you can basically do 90 on every section, and it doesn't matter, it'll hold the same.
Oh, 90, wow. Even the 4-foot?
But I still like 130. 130. So the way that you're tensioning this is you're turning it so that you see these little circles? The 130 spot is at the end. So you're gonna turn it clockwise all the way till you get to the 130.
You feel your tension as you go.
Just grab it. With that, you have to grab the handle.
Keep going,
And
yeah,
with your right hand. You see the handle? In front of your hand. Just in front of
keep
your hand.
going.
Yeah,
One more.
you do that. Just look at your hand.
Okay,
Look at your hand.
that's want to. And now,
That'll hold the
don't
wire.
let it go yet, so now leave it like that,
Try and pull the wire.
and then now lock that. So now the main thing here is that you wanna keep this counter torque, right? So keep this hand straight and then just turn this one, so you can lock it.
One of the biggest issues that could happen at this point right now, and we could do it just to show you guys, is you could kink your wire right here by being like soft on this hand. You could kink it right there, and that'll almost guarantee a broken wire, and you gotta bring the patient back.
Yeah, or a broken tibia.
Yeah.
Meaning if you don't hold the one hand steady. and
Yeah,
you-
so this is your
Yeah.
counter torque here, so
Yeah,
if you
so
just like
don't-
kink it, and then all of a sudden I'll see it right there, and I've actually like told people mid-case, this little tool, the counter torque, and you're just gonna go back and forth like this, hold it tight.
Got it.
So go ahead, you try this. What's your name?
Alexia.
So Alexia, you're just gonna go back and forth, watch your finger.
So before you.
It really hurts if you get
I
stabbed.
would recommend.
And what, yep, see now how nice and tight this is? Like nice and, there's no sharp.
So what's wrong with this? Oh, no. This is not right down where the middle should be. So now you're okay because you haven't locked it in, so you could just move the phone.
In real life.
But in real life, that's not gonna happen.
I don't know, we
Want the tibia to be in this direction, slanted like this, right? You want it to be really nice and straight, kind of like that, right? So, because if you do it like this and then you're trying to undo it again, then it's a little bit harder. So let's, so what I was telling them is that in order to keep this stable, so I don't have to worry about holding this, I'll do 1, 2, and 3, and then I'll hold it all together, in that manner. So you try to do it right up against the frame better.
So if you want to
So
do
you
it,
wanna do that?
a lot like that, and then you just wanna kind of,
I'll hold it, you just
just
want
wanna
to
ball.
ball. That one will give you, so you want to lock one first?
Yeah, you wanna lock those off. If that one floods,
Let me push it to
you can kind of, yeah, this one before you ball. Or, yeah,
You gotta hold this, buddy. Yeah, both.
Do you want me to just?
Joystick you can use. See it?
And right up against the frame.
So
Yeah.
you're gonna push this
So you can
down
let
towards
it
the
go a
ball,
little bit. Okay.
and then it'll slide over.
So why don't you let it?
You see this thing? That's what you're talking about. So you can have this side. But you can do that.
You can let
Move it,
that
hold it in.
And then
Yeah, they don't have
go
to use
back.
symmetrical, 'cause if you
Let
want,
this go.
you know,
If you were
About just putting this, and this. I just do everything the same, and then in my other whiles, I'll do everything opposite.
Okay.
They
Alright.
end up leaving within
Easy.
about a year.
You got it.
because
You
they
got
don't know what
it. You've already been in the case for 2 hours.
Yeah.
You don't want this to be another 2.
Yeah.
So 1, 2, 3. Tighten, tighten, tighten. Tension, 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 and then the other.
Tighten, tighten, tighten.
was there before.
yeah.
Yeah, she.
So do there 90. You don't want to do 130 then. You just want to do 90.
Well, even then.
So 130, 130, 90.
I think you bent it this, and then you gotta switch it around.
Oh, there's a back piece?
There's a back piece, so then you shim this in.
It's entire time.
Yep, now take it off. You just go, so you just flip it around. So the right medical one, you can hook on the sides, and it kind of locks in on the frame.
I do that. There you go. Keep going. Okay, good. That's it. Okay, so now we're gonna make it so that when we tension it, it goes that way.
But this
okay?
one, you can,
So let's
you can put it
tighten
right
this
on and
one
then
and then we'll tension
Yeah,
it
because
there.
there's just very little time.
Do you have another